Welcome everybody to our fifth, Shane had to actually correct me, it's not the fourth, it's the fifth NGMC GME Research and Quality Improvement Symposium. This is our fifth keynote. I'm so excited that everybody's here and supporting the early career physicians. And to all the senior leadership, it's a real positive, critical message to the medical staff about the value that you place in evidence-based medicine. My name is Dr. Louise Jones. I've had the honor and privilege of leading a very special team of methodologists, biostatisticians, and research data experts over the past 5 years. We support close to 200 research and quality projects each year. Typically, each team member wears multiple hats, and our success relies on them being able to juggle these responsibilities with a really high proficiency. They're experts in their own fields, the fields of research and quality improvement, the role of research and quality educators, and each leads a program initiative, such as one of our pipeline programs, our research electives, our grants, and our event planning. Mary Flores, our senior clinical research coordinator, has headed the symposium event this year, the event planning team this year, leveraging her project management expertise and talents of her planning team, Callie McDonough, Jeffrey Yawn, and Dr. Anna Tucker. I'm so thankful for her leadership and their skills. Thank you, everyone. Thank you to the rest of my team. It takes all of us. Shane Robinson, our research manager, Jake Slayton, our biostatistician, and research coordinators, Drs. Hardeep Singh, Eric Evans, and Tahani Dakak. Of course, PR and marketing's Marie Kruger and the Robbies have done a marvelous job with all the graphics and videos and photos, and the CME team is as magnificent as usual. Thank you finally to our amazing faculty and NGHS staff who bring their expertise to judge these posters and podium presentations. This is truly the gold in this event, expert timely feedback that feeds forward into better evidence-based providers. There's no commercial support for today's program. The speakers and planners have disclosed no relevant financial relationships with commercial interests. If you'd like to claim CME credit for this event, make sure that you sign in and complete and submit the exit survey at the end of the presentation. Just want to say thank you to the CME team for their support and guidance in the qualifying process, but also for their media support and the interviews that they do. It just increases the richness of this opportunity. Our conference theme this year is improving the health of our community in all that we do, and it should indicate to everyone how important we believe developing quality improvement skills and techniques, and importantly, that gap-spotting lens of the healthcare provider. Why do we spend so much time working with resident physicians through real-world research and quality improvement opportunities aligned to the issues right in front of them? Modules don't work. That's what everybody else's programs tend to do. Facilitated experience works. I was really excited when Larry Dudas and Paul Needham agreed to do this year's keynote. Dr. Dudas, our VP of Medical Affairs, has been a huge supporter of GME quality this past year and a champion of fact-based improvement across the system. When Paul Needham joined us last fall, stepping into the role of Executive Director of Quality and Accreditation, as a self-professed data head, it became clear that our system was entering a new era of data-driven quality improvement opportunities. Seeing them interact together was both inspiring and energizing. I'm delighted that you now get the same opportunity. Please welcome Dr. Larry Dudas and Paul Needham to talk about why quality matters, the pursuit of zero preventable harm. Thank you.
All right, thank you guys. Everybody hear me okay? Great. So thanks, Lisa, appreciate the introduction. You know, Paul and I are honored to kind of come up here and talk about quality, spend some time navigating that process and talking through sort of some national trends and wherever that is, data nationally, kind of what we're doing here locally, and then also kind of when quality, what quality looks like when it's good. So we'll navigate through a lot of that over the next 30, 40, 45 minutes, depending on how long we talk. Could be 2 hours, I'm not sure. So yeah, as Liz mentioned, I'm Larry Dudas. I'm a hospitalist, internal medicine trained, and recently took on the role of VP-MA. And here's a picture of my family, right? So my wife, Katie, she's a family medicine doc here with us. My son, Luke, and then my daughter, Zoe. So a funny story about Zoe is she's like, what even is VPMA? Like, are you even a doctor anymore? Like, did you lose your doctor degree when you were a VPMA? So no, it's very, the kids run us ragged and keep us busy, but it's great. So so me personally, here's just kind of my training at a high level. Went to University of Georgia. Actually grew up on the other side of Atlanta in Cobb County. Did medical school at Mercer University and then residency at South Carolina. That's actually where I met my wife, was in residency, first day of residency, and then we've been together ever since. So, so that is me, and I'll hand it over to Paul.
Yeah, so thank you again for having us today. My name is Paul Needham. I'm the Executive Director of Quality and Accreditation. As Luis mentioned, I started back in September. Moved up from Florida with my family, so this is my family here. My 3 kids, Nora, Ezra, Owen, and then my wife, Christina. And that is a bookstore that we owned before we moved up right behind us. So she's done all sorts of things. I've been a teacher previously, and then I have been working in healthcare for about 10 years with a data and analytics background. I got my undergrad from Florida State University and my master's from University of Central Florida, from North Carolina. So this is a little bit more of a familiar area to me. So again, like Dr. Dudas said, we'll talk a little bit about quality and safety, what it looks like in the U.S., what it looks like here at NGHS. And then for our residents and really everyone here, how do we fit into that picture of improving quality and safety at NGHS? So I want to ask you, this is an interactive portion, so you may pull out your phone. I'm going to ask you for some of your feedback. I will not take your email or phone number and sell it to anybody. This is just, I want to get your feedback and get us started thinking about quality, patient safety, and some other things related to that. So take a moment if you want to scan that QR code. I'll take it down in just a second, but you'll have another opportunity to get it up. I think there are about 5 questions. Well, let's just do the old school version. Let's get some voices. So think about an incredible restaurant experience. Just call out some words that help us think about think about a specific restaurant that you've been to. If you've gotten to go to one of the Michelin star restaurants in Atlanta or somewhere else, or something around here, something on the square, what are some words that describe an incredible restaurant experience? Great food, okay? Ambiance, service, what else? Clean, okay. Yep.
It's a good one.
Delicious, okay. So a lot of different things. Great food, service, delicious, ambiance, vibe. All right, so let's move on for just a second. Think about an extraordinary vacation. This is a leading question. So I'm going to read through the selections here. I just had a team member come back from a vacation and describe an extraordinary vacation. Which do you think is, you can shout out A, B, C, or D here. Number 1, your flight was on time. Does that make an extraordinary vacation? Number 2, you got hepatitis A, I'm sorry, hepatitis A.
None of the hepatitis are good to get, so it doesn't matter what letter it is. You don't want any of them.
Hepatitis A from my hotel salad. And I have to be very careful because my dad was a pilot and he actually got that. And for at least a few minutes, I was like, oh, you got hepatitis C. And people are like, don't say that. Hepatitis A, he got hepatitis A from his hotel food. Number 3, is it a great vacation if your host, Nick Saban, did not live in your Airbnb? And then D, this was the experience of one of my colleagues. She saw the Northern Lights every single night when she went to Alaska. So if we were going to select one of those, A, B, C, or D, which one describes a great vacation? D. A is good. C is good. You want that. But D is really what we're looking for in a great vacation. Most of what we've said is aspirational. These are the things that we want to accomplish. We're thinking about quality versus patient safety. Sometimes they're synonymous. Patient safety is usually more about avoiding the bad outcome, where quality we think of as aspirational. So let's think about this. What makes a great healthcare experience? What are some words that describe a great healthcare experience? You don't get hepatitis. Yes, very good.
Didn't know we're going to have a GI-themed talk here, yeah.
And thank you for your participation. You guys are doing great. Good bedside manner. Being heard. Great.
Being healed, maybe?
Being healed. Efficiency, I think I heard. You don't get hepatitis or anything else bad happen, no adverse events. And then we'll just think about this one. If a patient acquires eclampsia, so let's think about this now, what it's like to be a patient. If you get one of these safety events that we measure, we monitor, we work to prevent, we work to reduce the risk of getting one of these adverse events or harm coming to our patients. If a patient acquires eclampsia, how much does this increase healthcare costs on average? Now you could go to a lot of different studies and see a lot of different numbers, but I'll just go ahead and spoil it since we don't have our polling capability. It's about $11,000. So as we're trying to think about being a responsible health system, cost is important. We want to take care of patients, and we want to make sure that we can continue to have the ability to take care of patients in the future. And that's a big conversation here, but across the country and across the world. What is the increased relative risk of mortality for a patient who acquires eclampsia? So sometimes we aren't cost conscious. Some patients are, some patients may not have to be based off of insurance and financial situation, but this would affect every patient. So increased relative risk of mortality for a patient who acquires eclampsia. Again, different studies, different places, but 37%. So increased relative risk of mortality. So if, I would say if you have anything that increases your relative risk of mortality by 37%, driving a car or anything else, that's a big number. So thank you again for participating, just getting us warmed up, thinking about this for a minute, and now we're going to transition into Dr. Dudas is going to review a couple of studies for us.
All right, thanks, Paul. So, like we mentioned, what we want to go through here is talk about why safety is important in healthcare, number one, kind of the impact it has from a quality of life standpoint, of the community, but then also looking at some cost stuff as well. But then, there was a landmark study, right, done in 2000 that came out from the National Institute of Health, talked about to err is human. A lot of you guys have probably heard of that, right? But it talked about why healthcare is not safe and why it's not a safe industry and how all this bad stuff happens when you are come in the hospital. Just coming into the hospital was risk. It was a risky proposition. So what we're going to kind of walk through just in the next couple slides is taking that data from the 90s, which was reported in 2000, and compare it to a New England Journal of Medicine article that came out in 2023, which had data a few years before that, but to say, hey, are we doing better? Are we not? And really, why is this important? Because we'll talk about reporting and how all that data is reported. Now, at a high level, right, healthcare should be a high reliable organization. If you come into the hospital, your loved one comes into the hospital, you should be able to expect to come in and not get hurt, right? And with that, to be a high reliable organization, what we try to mirror our processes after would be other highly reliable industries. And the three most highly reliable industries would be naval aviation, right? You got a bunch of young kids flying airplanes in the middle of the ocean on an aircraft carrier, commercial aviation, and then nuclear power, all very high-risk industries. So with that said, just throw another question out there. Does anyone know what the safety event rate is for commercial aviation? Essentially, how many plane crashes occur in commercial aviation? Someone just throw out a number at me.
Last year?
Wait, 2024. 2024 data is what we have. It's gone up a little bit, right? 0.01. Close, very close. It's 1.25 plane crashes per 1 million plane flights. So that's a lot of zeros in front of a 1.25, right? So looking at the data here into error is human, this is kind of what this landmark study showed, right? It showed that there were a lot of deaths, right? 50 to almost $100,000 estimated, or 100,000 estimated deaths per year in the 90s. It was the 8th leading cause of death according to this, but if you look at the data and dig into it, some people would argue it might be as high as the 4th leading cause of death. And then you have medication error rate, which is super high, right? 3.13 to 4.5 per 1,000 medications given. We just talked about airline, right? 1.25 per 1 million, and now we're talking about 1,000, so a significantly decrease in fold there. Serious safety event rates for the ICU, you guys can see there. Surgical serious safety event rates of 2.7, so 2.7 per 100 surgeries, there was something bad that happened. And then a serious safety event rate of anyone coming in the hospital of 4.4%. So there's that, right? And then, so what was the cost? So for some reason, they picked Colorado and Utah. I have no idea why, but that's where the data came from. But if you extrapolate this data out as to all the US, you can see back in 1992, the cost of medical errors was $37.6 billion. $17 billion of that was preventable. And the most recent data based off that New England Journal article, and really some other articles as well, that were estimated to be between $20 and $45 billion just for hospital-acquired conditions, not other serious safety events related to that. So extremely high numbers. So if you do that compared to this New England Journal article, which was published in 2023, but had data actually from 2018, you can kind of see the serious safety events rate was that. So 23% of admissions had one adverse event, 7% of admissions had a preventable adverse event, 1% deemed to have a serious safety event, so 1 out of every 100 patients kind of getting harmed by coming in here, and then 0.5% of those were fatal. So if you just were to look at that and just kind of compare that data to what we do here, and I will be happy to say our numbers are significantly better than this, but we do about 38,000 discharges per year here. And if you were to take that data back in 2018, take it to our hospital, that means that we would have 43 patients dying in our hospital due to adverse events. That is not true. I want to be very clear, that is not happening here, right? But with that said, it just talks about the risk of death, essentially, just by coming in the hospital. So top 3 adverse events in the study in New England Journal was drug and medication related, procedural, surgical, and patient care, such as fall, escalation, and pressure injuries. Be very honest, in our hospital, we still struggle with falls, escalation of care, and pressure injuries. Those are 3 focus areas, which we're going to talk about a little bit more here shortly. So drug and medication related. So just a brief story. Does anyone remember the Vanderbilt nurse that had a lawsuit come against her due to a medication error in 2018? Just out of a show of hands, just say, does anyone remember that? Yeah, pretty large amount, right? That was catastrophic, right? So this poor nurse went to sedate someone for an MRI. The doctor ordered Versed, went to go get Versed out of the Pyxis, types in VE in the Pyxis, has good intent to give the patient some sedation for an MRI, right? Instead of pulling Versed, pulls Becuronium. So pulls a paralytic. Administers the paralytic to the patient, sends her through the MRI, she comes out, coding, and then she is brain dead, right? It wasn't the intent of the nurse to do that by any means. It was a system that was not set up to support the nurse, and it was a system that was set up to fail. It wasn't the nurse that failed. So with that, as we talk through this, we're just going to talk about how systems are important, why quality improvement work is important, and why setting up systems that set providers, whether you're a nurse, a respiratory therapist, a doctor, whoever it may be, to do the right thing and make it easy to do the right thing. So as we talk about the comparing, again, 90s to late 2010s / early 2000s, or 2020s, are we doing better or not? So looking at this study, you would see that there were some improvements in how we're collecting data, how we're collecting serious safety events and all of that. So what we have now that we didn't have back in the 1990s was event tracking. So everyone's kind of heard of our RL system here, but that's how we track serious safety events. We have an EMR now. I think when I first came here, we were on paper. When I trained, I was on paper. Dr. Raja, were you on paper when you trained? Or yeah, so a lot of us trained on paper, right? And now we have an EMR that's robust. We've got this huge hundreds of millions of dollars EMRs across most of the hospital systems in the country now. So that EMR allows us to be able to collect data better. So now we're collecting failure to treat and failure to escalate, where previously we did not do that into error as human back in the 90s. And then lastly, based off the EMR, we're able to track hospital-associated conditions much better now than we did then. So the thought is our reporting is better now than it was then. Our rates are questionably similar. So the thoughts are maybe we're doing a little bit better, but it's really undefined at this point. So the study from the New England Journal article 2018 or 2023 from 2018 data was good people working in poor systems, right? That Vanderbilt nurse is a obvious example of that. Reporting is improving, so I think that's a good thing. The more we're able to report, the better. And there's kind of conflicting data on if we're truly driving down our patient's safety event rate or not. So with that, we're going to kind of talk a little bit now. I'm going to hand it over to Paul to talk about kind of how we are looked at from a quality standpoint here at our system, places that we report to, and how we're doing. So there you go, Paul.
Thanks. So we'll talk a little bit about our quality programs that we do pay attention to, and ultimately we want to see how really everybody in this room fits into quality improvement. So at the end of this talk, I think the goal being is what we're doing working. We see from the national trend that maybe it's not working as well as we want it to be. Is it working here? So a starting point for us, I think, and in response to a lot of these studies, is that a lot of these quality improvement and quality measurement programs were put into place. Some of them are private. CMS is the government set of quality improvement programs, and I think there's a lot of conversation you can have about whether these are good, effective, appropriate. Do they compare like hospitals in a reasonable way? Does it make sense? And I think as we go along, the main takeaway for me is these are not perfect programs. There's a lot of things you could spend a lot of time complaining about, but what they have done is they have caused hospitals like ours and others around the country to focus on quality. How do we make it a better experience and a safer experience for our patients? So just some examples of what it actually measures. This is nothing to memorize. We have all of the acronyms that are all over the place in medicine. This is a new layer of acronyms that is kind of its own special version. But really what these programs measure is a wide range of quality indicators. Readmissions, mortality, patient experience, infections, complications, surgical, non-surgical complications, cost of care. And some of these are better than others. I think the readmissions measure, thinking about readmissions as how effective are you at coordinating care? You as a hospital are no longer just responsible for getting the patient out of your hospital alive. Now you have some responsibility to ensure that their continuity of care is maintained, that that your patient gets to the next site of care, the appropriate site of care, with the resources that they need. So again, a lot of these programs are not perfect, but the direction is to push us towards taking accountability and for our patients beyond just what happens. Did they survive the hospital? So a lot of these programs, we pay attention to these measures. We get a map like this, so you can see where Gainesville is. Not all of our hospitals have a leapfrog grade. These are our leapfrog grades, so you can sort of see the environment around Atlanta. Most of these A grades are smaller hospitals, but we get this public information. The idea is to have a more informed consumer. So we're evaluating hospitals. We're being evaluated and getting a grade, hoping to inform consumers about where to go. In an industry where a lot of times patients don't really have a choice. They need to find emergent care and they need to go there quickly. So geography is more important in a lot of cases than just what your letter grade might be. Similarly, I know this is small, but CMS will provide something similar with a star rating system, measures 50 to 60 different measures, trying to combine it into one score and create an informed consumer. So again, I think the idea is these programs are not perfect, but what they've done is they've helped us to start focusing as a system to provide support for quality and safety initiatives with the ultimate goal of improving care. So we're going to look at a little bit of our data at NGHS, and again, how we really want to get to how does this impact patients, and how do we get a whole team of people invested in quality improvement. So we will not go through all of this, but this is more just to show we pay attention to this at NGHS. We have throughout every year, we have strategic planning related to our quality measures, not just at the hospital, but across the system in our post-acute areas and our clinics. We pay attention to falls. We pay attention to our sepsis processes. Are we implementing evidence-based practice effectively and consistently? We pay attention to infection rates. More process measures around medication administration, medication safety. And then in the outpatient setting, we're looking at prescribing the appropriate medications based off of patients' disease processes. We're looking at heart failure readmissions. So we look at this every year. We want to make sure that we are focused on things that we're not doing well in, relative to other hospitals, and how do we create systems and processes, not just in improving the number, but actually making sure that we're doing the right things to protect our patients and getting the outcomes that we are looking for.
Yeah, thanks, Paul. So a lot of these initiatives, right, that are drawn from our system level initiatives help really to drive our serious safety event rate. So this is our serious safety event rate. This is a 12-year rolling average of, 12-month rolling average of 2.51. So you can see the trends there and kind of where we've gone. So from a hospital standpoint, from our standpoint, a couple of the biggest drivers of that have been pressure injuries, have been failure to escalate. Those are probably the two biggest drivers that we have in that. That's why we really have teams that are coming together to work collaboratively, nursing, provider, to focus on these areas. I can tell you that from a failure to escalate standpoint, a big push we've had is communication. Communication amongst nurses and providers, amongst providers to providers, nurses to nurses, really that whole care team, and how can we leverage IT, whether it be secure chat or other avenues to make sure that we're communicating properly. But again, as Paul said, this is just a reflection of how safe it is here in our hospital. And to me, this is probably one of the most important graphs that we followed, because obviously if you come in here, you don't want to get hurt, right? You don't want to have a safety event occur while you're here in the hospital. So I'm very pleased with the trend that we've had, as you can see, this 12-month rolling average, and hopefully it will continue. But again, just a reflection of a lot of the work that goes on kind of behind closed doors from that side of things. So we'll kind of get into some of our specific data here within the hospital system and kind of how it looks and works.
Yeah, so we have a sampling here of some of our data. And I think, again, with the idea of focusing on resident quality improvement, I think one of the things that's important to note is that when we do quality improvement and we do it well and we put resources around it, it works. We see improvements. Falls is a great example for us. And, it's not just let's get the graph to go down, but let's implement the right protections for the patient. Let's make sure we're hourly rounding. Let's make sure that when we go into the room, we're being proactive with the patient's needs, with toileting, that we're creating a safe environment. We're evaluating the patient for risk, and we're putting in interventions to either prevent falls or just reduce the risk of fall and reduce injury. So falls is something we've been focused on for a while, and we continue to improve, and it is something that we continue to work on.
You guys don't know this, but I know the next one is going to be CLABSI. So, so the other, I guess at a high level, right? Falls, CLABSI, quality, all of these really help to drive our scores, right? Paul talked about our leapfrog scores and our CMS star rating. So a lot of these focus areas that we're kind of going to go through and show you these graphs on are really drivers of our leapfrog scores and CMS star data. So the next slide here, it speaks on CLABSI, and that's a focus area for us because number one, it's a safety issue for patients, right? We want to drive down our CLABSI rate, number one. But then number two, that also is a reflection of our score. So the less CLABSIs we have, the higher our grades are and all of that. But ultimately, it's keeping the patient safe and doing the right thing for the patient. So our CLABSI rate has gone down as well with work that we've put in from a multidisciplinary team when we talk about bundles for our CLABSIs, making sure that we're doing the appropriate bathing, making sure that we're actually have blood culture stewardship as well. We're getting cultures appropriately with the help of our lab team, right? That we'll make sure that ensures that we're collecting blood cultures in the appropriate way through a process in which we are kind of filtering what they call the skin plug, so you go take a blood culture, you put a needle in there, so it kind of removes that skin plug to reduce your risk of contamination and potentially false positive blood cultures, which then leads to a bunch of other stuff with that. So I think the next one's CAUTI.
CAUTI's the next one.
Yeah, CAUTI. Pretty sure it's CAUTI. So CAUTI as well, again, same sort of thing as CLABSI, where we talk about how we are driving down our patient harm by reducing our rate of CAUTI. With that, it's been a lot of work, and really the past 2 years to get CAUTI going appropriately. So we had multidisciplinary teams that came together to look at urine culture stewardship, to make sure we're getting Foley catheters out, working with our IT team to make sure that we have the appropriate order sets in place for Foley catheter utilization and removal, along with really focusing on our IDT rounds and how we look at this within both the provider side, the nursing side, and really it's the care team to determine if Foley catheters are necessary, because if they're not, let's get them out. You don't have a Foley catheter, you can't get a CAUTI. So that's a good thing too. I'm trying to remember what the next one is.
Stroke mortality.
Stroke mortality. You remember that one?
I do. So at a recent meeting, our stroke team shared their really a comprehensive view of their stroke program, and they have very, very impressive results related to stroke mortality, which in a lot of cases, for stroke, time is brain. So not just mortality, but reducing deficits, making sure the patient can get back to function. Timeliness of processes is really important. So that's where, in a lot of cases, quality improvement is essential. How do you get patients to the hospital quickly? Once they're here, how do we get them to the appropriate treatments quickly and appropriate interventions if needed? So hopefully we'll be able to share that, but our stroke mortality here is significantly lower than the national average. And I think it's an important reflection of the work that we do, the effectiveness of the work that we do, and then the pride we can take really in talking to our community and patients to say, when you come here, you have the best chance for not just survival, but the right outcomes, the best care. You know that that's the quality discussion versus patient safety. We're going to get the results that you want as a patient after a scary life event like stroke.
I think that's something that's so important because these stroke patients, right, it's a multidisciplinary team, right? You're putting order sets in place, you've got physical therapy, you've got nursing, you've got neurologists, you've got neurointerventionists, you've got ED docs, you've got just a wide collaborative effort to really help improve our stroke numbers, just because that's such a patient population that's at risk when they walk in the door. So Claudia, we touched on. So pressure injuries, right? This is something that you'll see the number here isn't as good, right? This number is not as good as if you look at compared to our CAUTI and CLABSI numbers and our stroke as well. So that's an opportunity for us. So I think that we've had a lot of focus on this moving forward. I think this is where our opportunity is to really drive down that serious safety event rate, and really where the opportunity is to help our patients be safe when they walk in the door. So we're excited to team with nursing, and I know our nursing leadership has really implemented a lot of new and innovative stuff to help prevent pressure injuries with turning and documentation and leveraging Epic and things like that. So there's a lot going on to really help with our pressure injury reduction work. So we're excited about that. And hopefully in the next 1 to 2 years, we'll start seeing those results. Because like everything else that's complex and complicated, it's not like you just flip a switch and you get better, right? It takes time. It takes time to develop processes, to implement them, and then really see the results. So hopefully we will start seeing that. So I remember when Lucy called me, one of the questions she had is like, hey, how can residents really be a part of this, right? How can they feel like it's impactful and sort of what's their role? So I think one of the big things I want to make sure we hammer home here is that everyone can be a part of this, right? Everyone here can be a part of continuous process improvement. We call it, right, PDCA, Plan, Do, Check, Act. So you have a process, you have an issue, you evaluate it. We have what's called A3 thinking. We evaluate what the issue is. We kind of say, hey, this is what our root cause is. These are kind of our next steps to implement to hopefully improve whatever's broken, right? And it may work or it may not. And if it doesn't work, that's okay. You go back to the drawing board and try again. So I think that's something that's very important. And I hope part of our culture here is to have a continuous culture of process improvement. So what have residents done here? So I'm not going to read through all of these, but I think it's just very impactful to know as a resident you can make a difference, right? You can see there's multiple quality improvement projects focused strictly on quality and safety, healthcare utilization, population health and preventative care. You guys can read through those, but as a resident, you guys make a difference, right? What you do has a positive impact on patient care and how we deliver care at our hospital system. So it's just cool stuff. I mean, you talk about CT screening, you talk about heart failure readmission, you talk about reduction of CAUTI. It's just a lot of stuff that as residents, you guys can contribute to. I know personally, like when I was a resident, I was like, oh man, I've got to do a quality project. I just want to go see my patients. I want to show up in the morning. I want to get my rounds done, get my notes done, and then try to get at least a couple hours of sleep so I can get up in the morning and do it again, right? But there's more to that. And you guys are fortunate to be in a system that has a focus on quality and process improvement that personally I didn't have. I had to learn this stuff outside of residency. So I think it's very exciting and really speaks volumes to our GME team and what they're doing here. So, hand it over to Paul.
Sure, and we wanted to touch on just culture as a part of this, and Dr. Dudas has already alluded to this, that a lot of the approach here, and we won't go into a full discourse on just culture. Our HR team does a really good job of that. But the big point being, we have people in imperfect systems, complicated systems. Our systems are becoming more complicated as we grow and as medicine advances. So when you are at the bedside, you are the best advocate for your patient and that have the highest visibility to what's happening and maybe what's not happening right or could go wrong. So a lot of this is being involved in quality improvement projects, reporting when you see something goes wrong or might go wrong or doesn't feel right through RL. And ultimately, our approach is this just culture approach, which is we want to create high quality systems to support our team members. We want to create systems where it's hard to fail, easy to succeed, and hard to fail. So with that in mind, I think one of the things we're talking about at the beginning, patient safety a lot of times is, hey, nothing went wrong, so we're good. My flight was on time. I got my order right. But that doesn't necessarily mean that you had a good experience. That doesn't necessarily mean that everything went the way you really wanted it to go. Maybe someone came and they eventually they got healed here. They came to the ED seeking services and ultimately they left home and they were fine. But we want to tell. I think quality is the difference between quality and patient safety. A lot of times is that quality is in the story of the patient. And you see these stories at the bedside. Data is important. We want to know that what we're doing is happening consistently, that we can identify trends. But it's also important to understand the individual and the patient's story. And I think that's a lot of times where we see quality. We see the accumulation of safety. We see the accumulation of quality improvement. So we're going to talk briefly, just tell the story. I know a lot of you may know, because apparently he is a local celebrity. But I reached out to the stroke program and said, hey, tell me about a patient that has a great story here. So this is Mr. Eager. He's in our community. He's 81 years old. He lives at home. He's with his wife. He's very independent, and he loves golf. Now, I don't know how you all feel about golf, but really what golf represents, so think about your thing when you're retired, your retirement skill. It's the thing that you get outside, you're active, you're social. He plays golf with his buddies. It's mentally stimulating. This is something important to him. And so Mr. Eager, one July evening, was sitting with his wife, and as they were talking, she noticed fairly quickly that his speech became slurred. The left side of his face started to droop, and he started to have paralysis in the extremities. So she immediately called 911. Habersham EMS showed up, evaluated him pretty quickly, noted that he had pretty significant deficits, got him, initiated transport to Gainesville, called a stroke alert as they were coming over. He got to the ED. They responded quickly. He had an NIH stroke scale of 13, which is a moderate stroke. And we got him to CT. CT confirmed ischemic tissue, confirmed an occlusion, and ultimately got him tenectoplase within 15 minutes, a door-to-needle time of 15 minutes, which is incredible. We mentioned it before, time is brain, 2 million neurons a minute. So then from there, we took him over to the IR suite. He had a thrombectomy within 90 minutes of admission, and ultimately achieved perfusion within 175 minutes of the onset of symptoms. So on the left is prior to intervention, and on the right is post, where we can see perfusion achieved.
So in the neuro world, we want to see a bunch of spaghetti on there, right? The more spaghetti, the better. Other than that.
So yes, we achieved spaghetti on the right side here within 175 minutes of onset of symptoms, where time is brain. And so Mr. Eager then went to neurocritical care, had support of OT, PT, speech, eventually acute care services, and then eventually discharged home to his wife with support of services. And so and something I forgot to mention, he left the IR suite with an NIH scale of 1. So from 13 to 1, post-intervention, which is really just incredible. Went home, had supportive services in the post-acute space, resumed golf, and remarkably didn't just resume golf. Apparently during OT and PT and all that, he was talking, hey, when am I going to be able to play golf again? When am I going to be able to go out with my buddies again? He was hitting golf balls, putting, actually on the unit. And so as part of his story, he became an advocate for stroke. His wife had been educated. The education that we do matters. His wife recognized these symptoms. He invited the stroke team to come play golf with him and his buddies and do some education. He invited the stroke team to come to his church and do education. And so he's just a significant advocate for our work, stroke care. And I think going back to quality in the story is so much could have gone wrong. Maybe his wife didn't recognize what was going on. Maybe EMS doesn't show up quickly enough. When they get them here, our stroke team, what if our stroke team hadn't worked on our door-to-needle time? And we're just saying, you know what? Hey, you know what? National average or what we need to do is good enough. 15 minutes that's too fast. We don't need to do that. Or they don't care about it at all. We're not getting to the IR suite quickly. Our post-acute services aren't coordinated. So much could have gone wrong just because if we just don't care about connecting those pieces. And the story is very different. Story would be very different. He discharged with no deficits and is able to live his life with his wife, with his friends, with his family, almost as if nothing had happened, although we know his life is changed. So here he is with his golfing buddies, and just a really great success story of not just, hey, does our graph go down? Are we getting better times? But are we really achieving the patient outcomes and the improvement in the story that all of this work is really supposed to accomplish for us?
All right, thanks, Paul. Paul made a comment about golf being mentally stimulating. When I play golf, I've got to deal with a lot of high numbers I write down on my scorecard, so it is mentally stimulating to add all those up. But I think our mission here at the hospital system, right, is to improving the health of our community in all we do. And I think quality and patient safety play a significant role in that, and GME and residency plays a significant role in that. So I think as you guys mature as residents, right, and as you grow in your skill set and you grow in your knowledge base of medicine, it's just important to realize that, yes, it is fantastic to show up every day and to take care of your individual patients on your list, whether it's 5, 10, 15, or 20 patients you're seeing that day, and doing a great job taking care of them, getting them better, getting them discharged, and that's fantastic, right? But when you participate in quality improvement work, you're not touching 5, 10, 15 patients every day. You set up processes and systems of which you are truly affecting the entire community, because you've got patients that are going to come in those doors 2 years, 3 years, 4 years from now that will be filtered through the processes that you put in. And if they are highly reliable processes, you will get a great outcome, and you won't affect 5 or 10 patients. You're going to affect hundreds of thousands of patients and ultimately improve the health of our community. So with that, I think we'll close. We'll open it to questions, but want to thank our GME team for inviting us up here, and happy to take any questions. Thank you, guys.
I asked Dr. Dudas and Paul to come because quality is often, you said it, you're doing your patient stuff, you're doing all the stuff you trained for and why you went to medical school, and it's just extra. And we hear that from residents. Why are you making us do this? They don't do this in other residency programs. This is why. This is why, because our community people really matter. So let's open this up to questions and see what they have to say.
Fall risk and mobilization. So I think that the more we mobilize patients, the better off patients do. I think the more we appropriately mobilize patients, the better off they're going to do. The longer they are immobilized, the worse they're going to do when it comes to hospital-associated conditions, whether it be pressure injuries, pneumonia, DVT. The other thing is, too, when patients sit around, right, they're just going to get more and more weak, which means that they may not be able to go home. They're going to need to go to subacute rehab or even long-term care and potentially not get back home. So I think in my mind, it is extremely important that we mobilize patients in a safe way. And I think there's the fall risk is significantly negated by increased mobilization. And the more we do it, the less that fall risk is going to be. So very good question.
As
Yeah,
a
and
former,
I think those kinds of questions do help us to think about, again, not just having the line graph that goes down, but appropriate measures. Is pure fall rate the right measure? If we're mobilizing patients, we're assisting them. We might have more falls, but they're more likely to be assisted falls, where they're supporting the patient. And then there are the ultimate consequences. So we really want to create a structure around these initiatives. Mobility is a huge thing for so many of these measures. That we want to think comprehensively what impacts the patient the most, not just improving our ultimate data here.
that's great, thank you. And as a former PT, that is my answer too. Very much so. In the UK, they had a big issue with this as well, and that we're on the same track, yeah.
It is. I mean, it's
Any other
such a big thing.
questions? Oh, sorry.
No.
Yeah, over
One
here.
up there.
Holly.
Hi, great talk. Thank you so much for those insights and just a great, excellent talk. So, compared to the manufacturing industry, and as we use the analogy for the airline industry, one thing that happens sort of behind the scenes of those industries is that they put signage about safety basically everywhere. My mom worked at Cargill for 37 years, and everywhere you turned, there was a sign that said, don't trip, please be safe. 100 days without falls or things like that. So, what role might that play within our culture to have increased signage related to safety within the hospital setting, or even in the outpatient setting, to help educate patients? And is that something they're thinking about doing, or is it inappropriate in the hospital?
No, I mean, I think there's opportunity there. I think there's opportunity, like every other industry, to make sure that it's forefront in front of everyone's mind, as to say, hey, this is important to us. This is why we want to focus on it. I mean, when you go to the airplane industry, right, that you hop on the airplane, that's what they say. Hey, we're here to give you a safe flight. And I don't think when you walk in the hospital, we don't say, hey, at this point, we're here to give you a safe hospitalization. That's kind of expected, right? That's expected and anticipated. When you walk in those hospital doors, we're trying to heal you. And I think that's what the expectation should be. But I think there's probably some opportunity to that. I don't know, what do you think, Paul?
Yeah, I think it's a similar conversation to alarms, and making sure you don't have alarm fatigue, that you're not just ignoring the signs that are there. I think you can have plenty of signs. I think you have plenty of signs that don't mean anything because you just gloss over them. We're training to new huddle boards right now, and I think that's an important step of that process. Is how are you training to something to make it meaningful, to make the staff aware of it, make the teams aware of it, and really placing it in a place that is meaningful. Examples where you're putting a sign in a place where you're not supposed to store something, and that disrupts, that steps into your consciousness and you notice it. So I think it's something to be very thoughtful about when you do it, but not overdoing it so that you're creating fatigue.
So we have a lot of videos now. We have a Get Well video program, and there are 2 of them that are mandatory for patients to watch before they can watch other things on TV. And everything from a welcome to fall prevention to I think hand washing, infection prevention. So there's a few things. It's all being implemented. Some places it's working better than others, but it is a great program that we still need to, increase our culture of, because we're just getting started. But there's a lot of opportunity to welcome patients to the organization and to say, hey, we're here to make you better, and these are some ways you can be involved.
Yeah, I think it's a great example of how PR and our nursing education team can team with the providers to make sure we all have a clear, consistent message, for sure.
Good afternoon. I'm Nathan Boyes, one of the family medicine residents. So I've heard of us try to focus and emulate these high reliability organizations, say the airline industry, military often gets brought up. When I'm looking at those organizations, though, most folks are going through the same training, the same processes. And when I look around at my colleagues, some of us have trained, in similar schools. Some have trained, across the country. Some have trained internationally within different organizations, different instructors, different mission objectives for where they train. So how do we incorporate all of that into proceeding with a uniform way of doing things to improve patient safety?
Yeah, no, I think, a lot of it has to do with, I don't have a badge on me right now, but, talking about our safety champs, right? And our safety tools and being consistent with knowing our safety tools, knowing what our safety behaviors are that reinforce the tool, or safety tools that reinforce the behaviors and that sort of thing. So I think it takes time, right? You got a lot of people that are kind of coming in to assimilate into a similar culture, so it doesn't happen overnight. But I think the more we're able to be consistent with how we use our safety tools and safety behaviors, the more we're able to create that sort of consistent environment. But it doesn't happen overnight, right? Culture takes time. It's like moving glaciers at times. It takes a while to make sure everyone's using the same verbiage and the same lingo when it comes to patient safety. So I think that's part of our goal, though. That's part of our goal, is to assimilate that so everyone can really speak the same language and truly be invested in using those safety tools and behaviors.
Yeah,
Good question.
It's a great point. I mean, I think across the 13,000 employees, everybody's coming in with a different background, different expectations. I think a great example would be where we do commit to this is we have error prevention training for every new orientee, which is 2.5 hours as part of your orientation. So everybody goes through it. I went through it. I'm sitting there with physicians. I was sitting there with EVS workers, nurses. Everybody is going through error prevention, which is really just trying to make sure that we're consistent in our language and train us to take ownership of our hospital, of our health system. So I think consistently bringing people into this culture and improving the culture that we have, and being very purposeful about that is important.
I want to say thank you very much to you both. Fantastic and timely as well presentation, and we can help you with publishing. I just thank you very much for this opportunity, and thank you all for being here and listening, and hopefully absorbing and understanding why we put so much emphasis on quality improvement and research skills in residency. Thank you.
All right, thank you guys.